Good afternoon, everyone. Welcome to the sixth session of the National Commission to Address Racism in Nursing's third ECHO series. This series will have a focus on health equity. Whether you have been involved in previous ECHO sessions or are new to this space, we are so excited to be back and hope this interactive learning series is a place for you to find guidance and support. This program is brought to you by the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. This is an 8-part series. You will earn 1.5 continuing nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. Today's topic is how can cultural intelligence be the catalyst that perpetuates health equity? Before we introduce our speaker, we want to go through a few ground rules. This is a brave space, and discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger, so we please ask you to take the time that you need during and after the session to take care of yourself. We ask that you maintain respect for everyone joining us today, and to please stay on mute until it is your turn to speak. Also, listen intently and respond thoughtfully. And as much as possible, be present, limiting background distractions and multitasking when you can. Please take advantage of the virtual features available via Zoom. We encourage turning your cameras on and using the chat box or the raise your hand features to communicate with the group, but please remember to mute your microphone when others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information shared. If you share a scenario involving a patient, do not provide any PHI during today's call or any of the ECHO sessions. The presentation portion of our session today will be recorded. Our breakout groups will not be. Feel free to send a direct message to ANA ECHO if you have technical problems during today's call. So now we are excited to turn the presentation over to Dr. Angela Richard-Eaglin.
Thank you, and thanks so much to everybody for joining. I saw some names popping through that I recognize, so I appreciate people who are here, who have heard me speak before, showing up again. So thank you, and I'm going to jump right in because I want us to be able to use all of our time. Sorry, bear with me as I try to swap my screen. Okay, so we went through these slides already. I don't have any disclosures. Kara just read the slide. So this, if people attended the first session with Dr. Rumay Alexander, one of the questions she asked was, what's most crucial for health equity achievement? If anyone attended that session, does anyone recall? If you want to type that in the chat, if you recall what the answer to that question was. No takers. So the answer was curiosity. And so one of the things I love about cultural intelligence is that it teaches us how to ask questions with respectful curiosity. So it's a multitude of things. One of the things too is to want to be able to be effective in working with people who have backgrounds or cultures that are different from yours. You do need to be curious. There are 4 capabilities that I'll get to later on in the presentation and talk about why you need to be curious to even be interested, because one of the first of the capabilities is motivation or drive. And if we're not curious and have a want to know and a need to know in the space of health equity, then it would be hard to become at least moderately culturally intelligent. And I'm going to talk about that a lot more as we go along, but cultural intelligence teaches us how to be curious in that respectful and responsible way that's not offensive to people. So I want to remind us, why are we doing this? I always go back to this, that it amazes me that for 3 decades, we've been talking about the healthy people goals and the social determinants of health. And I just put the goals here. Economic stability. It's kind of hard to achieve health equity without economic stability. It's kind of hard to understand why some people don't have that if we don't think about some of the ways that racism, bias, and all the other isms show up and interrupt our ability to even achieve economic stability, to achieve access to quality education. And if you go to one of those schools that's graded less than an A, how does that impact all of those things? How does that have the domino effect on economic stability? And instead of stereotyping and labeling people, how do we become curious enough to find out why, the whys behind the whats? And let's focus now more on the how, because we know so much. We know, we have all the information. We've had the information for years, decades, centuries. But what are we going to do about it is what I want to say. And one of the things with cultural intelligence, again, it just keeps you in that state of mind where you're continually checking yourself and continually being curious and doing the learning that you need to do to understand why people experience life differently than we may have, and what things impacted that were beyond those people's control. And even if it was, it's not our job to judge it, but how can we think about the historical perspectives and the lived experiences of other people? Healthcare access is a big one, but quality is even bigger. And why am I not curious enough to change the conversations and do something to impact policies within the system so that we don't just put these values and norms and missions and all these things on the websites within our healthcare systems, as well as within our health professions educational programs. We really need to stand by and live the things that we say we're committed to, thinking about the environment that people live in. How does that continue to perpetuate disparities and prevent people from achieving optimal health, and also within the social context and community support? So what are we doing is the question. It's not about what's there, what's causing it. I want to know more about how I can change it more than anything. Love the Maya Angelou quote of do the best you can until you know better. Then when you know better, do better. Well, we've been knowing better. Now we need to do better and continue to hold ourselves and each other accountable for doing better. So we've known, like I said, for centuries. So why is that? I'm going to show you a video and then we'll talk a little bit after this.
Are you seriously considering her as a candidate?
Don't trust
She's a woman.
She's a woman.
This is a man's
She's
job.
clearly not educated.
Really? Does she even speak English?
That's not me. I'm not like that. You call it an honest mistake. Science calls it a blind spot. Our unconscious mind is a mysterious and powerful thing. It makes 90% of our decisions without us even knowing it. Our brains are overloaded with 11 million pieces of information every second. Yet we can only process about 40 of them. So we're wired to make cognitive shortcuts, using past experiences to make assumptions. And you know what happens when we assume? Our unconscious mind can put us on autopilot, determining where we sit, who we eat lunch with, who we turn to for advice, and who we choose to offer a helping hand. Living our lives with blind spots can put us in a tunnel. Same point of view, same decisions, same outcomes. We can find ourselves trapped in the land of snap judgments and misconceptions. We've all been on both the giving and receiving end of blind spots. Think about it. Who's talented? Who's able? Who can I trust? Who belongs? We've all been there. Blind spots are part of the human condition. Our choices have consequences for us and the people we interact with. By accepting that blind spots exist, we can stop. Imagine what possibilities exist if we could do it all over again. Different perspectives, inclusive relationships, diverse networks, better outcomes, seeing people for who they really are. People like you, with unlimited potential. We all have blind spots. Once you accept that you have them, you can choose to do something about it. It's time to check your blind spots and focus on what's possible.
Okay, so I love that. And one of the things, a few things stood out in there, but we do all have blind spots, and our blind spots are in large part because they're based on our lived experience and perspective. And so when we approach patient care in that way, or education, when we speak about it from an academic perspective, then it does, again, continue to perpetuate disparities. So the first step is admitting that you have them. And when we think about improving outcomes and how, I always like to say, sometimes people have challenged the use of the word bias management versus mitigation. You may never mitigate or lessen, reduce your biases, but you can manage those biases. You can become aware. And the cognitive behavior model is one of those models that helps us to see why, because we know sometimes we focus a lot on implicit bias, but so many biases are explicit. You know of some of the things you like or dislike, you prefer or not prefer. And so the key is, how do I not let those biases impact and influence how I carry out relationships with people, whether that's in personal relationships, professional, organizational. When we think about the determinants of health, it's outside of the healthcare system and within the healthcare system. So how do you stop those biases from showing up, from being activated? So you can have your own beliefs. Cultural intelligence is not one of those things that is there to change your mind, but it's there to make you mindful of how you're feeling and interrupt, again, the activation of those biases and allowing it to impact how you advantage some people or disadvantage other people based on your own personal preferences or lived experiences. So once you become mindful of your blind spots, then you can do something about it. And again, cultural intelligence is just one of those tools, and I will talk about that a little bit more. So again, the why? Why are we still having these conversations after all this time, with all the information, with all the research? We're having them for multiple reasons, but two of the big ones are denial. A lot of times we want to say we don't have biases, but every human being has biases, especially when you think about it in terms of preferences. Biases in isolation is kind of like a bomb. A bomb is not bad until you detonate it. Same thing with the biases. The other reason, and like I said, there are multiple, but one of the other reasons is inaction, and people don't want to see, hear, think, or talk about sometimes these things because it's a space of being uncomfortable. But I know you've heard it before, get comfortable being uncomfortable, leaning into the conversations, understanding that there is more than one perspective. Yours is not the best, it's not the wrong one, it's not the right one, and neither is another person's, and other people's lived experiences also should be valued. So I love to always talk about AAN's key takeaways. I was so excited when I saw that they had racism as a social determinant of health. That is definitely true. Again, you can have your beliefs and feelings, but those things, there is the research to show that racism does impact people's health outcomes, not only their lived experiences, not only their physiological outcomes, but mental outcomes and all the things that help us to thrive in society. And then we know that diversity and inclusion do advance equity. There are differences in opinion, thinking again about cultural intelligence, which helps us to consider trauma-informed care and trauma-informed responses from other people, and helps us to stop making those judgments and stereotyping, which I'll talk about a little bit more. But we do have to critically examine how we relate to populations that we serve. CQ again, and I will get to the framework shortly, but I like to build up to it. But it is one of those tools that is so good at helping us to examine why we relate to people and populations in the way we do, and how can we shift some of that to relate in healthy ways. And of course, I love the fact that this is focused on action if we're going to ensure a less racist future. And sometimes that action involves some uncomfortable conversations. That action does involve calling in different things, not just things people say, but also thinking about how do we examine the policies that continue to perpetuate racism, and understanding that it's beyond the social determinants of health. But in Daniel Dawes's book, he talks a lot about the political determinants of health. And I know lots of times some of us have been conditioned to think it's inappropriate to talk about politics, but we have to remember that in the space of healthcare and organizational change, politics rather drive policies. We have to focus on that. So we do have to talk about politics. We do have to remember that equitable healthcare and health outcomes is a human right. So we do have to unlearn some of the behaviors. Optimal health and social justice are human rights. So what we have to do is put legs on the words and operationalize the mission, vision, and values of our academic health professions programs, as well as our healthcare organizations and systems, because them just sitting there in isolation is pretty, is great. It draws people in, but once people come in, what are we doing? To people and with people and for people to help advance optimal health for people. So again, another video, because I find that these work to help people to really move from that cognitive space to that affective space when you see things in real life, when you hear the stories and you watch the videos, and this is one of those ways of putting some legs on the words so we really can feel what happens and how these things we do and say, whether it's unconscious or consciously, it impacts people in negative ways. people may have seen something, maybe you're guilty of it, and guilty meaning in a way that this is that leaning into the hard things that make us feel uncomfortable. You know, I'm going to be the first one to be vulnerable. We've all had those things where we judge and label people, again, based on our preferences and lived experiences. And the key to that is that biases, stigma, stereotypes, those are corollaries of isms and phobias. And those isms, stigma, stereotypes, phobias, they manifest themselves as behaviors. And in the space of healthcare is very dangerous. We think about sentinel events from a hospital perspective and how they harm people up to death. The same thing happens with stigma. So whether it's intentional or not, at the end of the day, it doesn't matter, especially since we know there are tools, because impact matters most. And I won't say it doesn't matter. Intention matters to the degree that you have a relationship with the person. But when we think about it in terms of health equity, outcomes matter way more than intentions, especially if your intentions aren't backed up by you doing something and taking the necessary steps to make those changes that interrupt those biases and disrupt those barriers to health and healthcare. The other thing, one of the things in there, I know the word tolerance sometimes is interchanged with acceptance, but I like to just go ahead and boldly say that tolerance to me makes me feel like somebody's being forced to do something, to be around me, to tolerate me. Acceptance is what cultural intelligence tries to teach us to do, to be more accepting of difference and moving away from the similarities and the space of comfort with people who do things the way you do them or think the way you think. So we also have to think about intersectionality, and that video kind of showed a whole bunch of the intersections of it's way beyond race in a lot of circumstances. A person can be a person of a particular race, but also have all those different cross sections of who they are, what makes them a unique individual. So as we consider health equity and patient care, we have to think beyond just what we see. I don't have it in this particular presentation, but one of the exercises that I created and like to talk about is no skin in the game. When we look at a person as a human being, taking off that very thin layer of skin that kind of perpetuates why we assigned race, right? Why race was assigned to us. No biological basis whatsoever. So if we could peel that skin off and see people as a human being first, and now that we have been assigned race, how does race affect us? Negatively, positively, how does it advantage some people? How does it disadvantage some people? How has it shaped who people are, who people have become, and how we're allowed in a lot of cases to function in the world? And then in addition to all these intersections, we also have to think about medical conditions that add a whole nother layer of those intersectionalities and how bias and stigma and stereotypes and judging and labels show up and continue to contribute to health disparities and inequities. So thinking of achieving health equity, I thought about, again, going back to Dr. Alexander's talk about curiosity, and I thought about CABS. The C's of how do we achieve it? Being curious enough to do something about it, not just doing the research on people, but doing the research with people, the people who are actually impacted, and not assuming that all people have the same needs or that all people have these disparities based on the same outcomes because they are of a certain race. And then being conscientious. Definitely, as healthcare professionals, it's so important to be conscientious and to be able to think about people as a human, as humans first, rather, a person as a human first. So to be conscientious, you have to have a conscience. And I know we all think we do. Well, I'm pretty sure we do, but does our conscience impact how we are not only caring for people ourselves, but how are we witnessing that and not doing anything about it? Are we being upstanders when we're seeing this stuff happen, whether it causes contention or not? Because I always think about in the space of healthcare, sometimes we have to cause discomfort to move toward that healing process. So I think about it in terms of an injection with a medicine that may be an irritant. I still need to give it because the whole objective is to heal whatever it is that we're trying to heal. The same thing here, even though it might be an irritant, it might make someone uncomfortable, we need to be able to move toward advancing the needle, putting the legs on the words. You do have to have courage to be able to do that. You have to have confidence. One of the things that cultural intelligence within the definition, it is the skill and confidence to be able to work in multicultural settings. So where is that more important than in healthcare? Because we do things on a national and international level, so globally, and even just within this particular country, we have people represented from all over the world. So how do we expand our purview? How do we become more competent in interacting with others? I very hesitantly use the word competence when it comes to culture, because it is my personal belief, again, disclaimer, my personal belief, unless you are fully immersed in someone else's culture over a long period of time, it's hard to develop competence. What I like about CQ is that you don't stay in one space. CQ is the abbreviation for cultural intelligence, because it's almost impossible, right? If you haven't been exposed. So in some situations, we're going to have a high level of cultural intelligence. In some situations, it's going to be moderate. And in some situations, it's going to be low. Is low bad in isolation? No. But if we recognize that we are low in terms of our intelligence in a certain culture, and we don't do anything about it, then that's when it's bad. And it does have to, one of the other C's, going back to the health equity, it does have to be a continuous process. We know in the space of nursing and healthcare, we have to commit to lifelong learning. We also have to commit to optimal health for everybody, and commit to getting those tools in our toolbox that help us to interrupt the biases. So the A in this is assessing situations, asking, being curious, becoming aware not only of yourself, but also how is your organization thinking and how are they acting upon the things that they say they're committed to, and then achievement. We can only do that if we're consistent in checking the systems, checking the processes, checking ourselves, and checking each other. And I do mean that in the most respectful way. And then behavior changes happen and better outcomes happen. And all this is bound together by integrity. So you see those words: respect, commitment, honesty, ethics, diversity. We talk about workforce diversity. So again, until we get to diversity, inclusive excellence, rather, in the space of academics, it's going to be difficult to achieve that in the space of healthcare. So we are looking toward an equitable future. I already talked about diversity. I already talked about equity, inclusion, and I like pictures to show us again what these things look like. Anti-oppression is interconnected, as I showed you in the intersectionalities. And then we want equity and social justice. And what that looks like is a balance, so that everybody, there's not this imbalanced opportunity based on things like racism. And knowing that inclusion, if you look at this picture, I'll focus on it for sure. Being in the same space sometimes makes people feel like they included you, but you see this duck is struggling. Oftentimes that's how it feels when you are from a minoritized population, especially when we talk about anti-Black racism. A lot of times it feels like you're there, but nobody's listening to you, nobody's seeing you. So you're included, but you're still invisible. You don't feel valued. You feel like you're struggling. As you can see, this little duck here is struggling. So we all know about racial bias. One of the things I want to point out about leading to misperception of reality and seeing things differently than they are. So there's a great quote that says, we don't see things as they are, we see things as we are. Again, that perception and perspective and how that makes a difference. So culture and perspective matter. The reason why they matter is because they shape the way we view everything. And we want to see things more from a global lens, and that means more than one thing, not just external or extrinsic things, but it also means from looking at people from the inside out, taking a deep look and trying to get to know people better, and changing your perspective, habituation of the humanitarian ethos and egalitarianism. So we said we signed up for those things that are in the humanitarian principles: service, mercy, respect for human life and dignity, trust, compassion, and empathy. And so we want to improve our self-awareness so that we can mitigate those biases and building positive association to people outside of the things that we have been conditioned to think and see about people who are different from us, and especially in the face of racism, so that we can become more empathetic. And cultural intelligence helps with that. And again, it's not going to ever be a one and done. We do have to be able to name and interrogate the issues, such as stigma, bias, and racism and phobias and all those different things, because language does have power. If we don't name things, then guess what? We continue to perpetuate all the issues because we privilege dominant groups and disadvantage the non-dominant groups, because we're still oppressing people from being able to speak up and speak out on the things that are negatively impacting health and health outcomes. Prioritizing research. And that means, again, what I said, we have to condition ourselves to do research in ways that partner with the communities that we serve, not in ways that we go and just do research on those people. We do research with people. And changing systems, as I already said. So people ask a lot. That's why I'm putting that here. How is cultural intelligence different from cultural humility, sensitivity, and cultural competence? They're all related. We need them all. I just say cultural intelligence ties a bow on that, and it helps us to become more humble, to have that humility, to be more sensitive. And again, the competence, remembering that it just depends on how you look at that, but we may or may not achieve competence. According to this CDC definition, it's congruent behaviors, attitudes, and policies that come together in a system that enable effective work in cross-cultural conditions. So that aligns really closely with the definition of cultural intelligence. But just remember that competence, to me, puts you at a higher standard, expects you to achieve a higher standard, whereas cultural intelligence gives you some fluidity, because we understand that you're not going to be the same with all groups and in all situations. So I kind of already gave you the definition. Just know that it is globally recognized. Cultural intelligence is globally recognized, and it is evidence-based, and the research in that space is ongoing. I told you there are 4 capabilities: drive, knowledge, strategy, and action, and they do go in clockwise in that way. So you do have to be curious to get that drive, to be motivated, to want to know more about people who are different, and gain that knowledge. And strategizing means that you have to be aware, you have to be able to deal with some of the guilt that often comes with the biases that we know we have. And you have to take some action. And I think I drove that point home, and be able to be flexible in those situations, even when you plan for a multicultural interaction. How can I flex? So thinking about that in the space of health and health equity, we're taught one thing in the books, but everybody doesn't fit in the box. Everybody doesn't fit in those, the evidence-based practices that we're taught. Those are a guide. But there will be some people who might be the zebra in there, and you need to be willing and able to see the zebra and treat the zebra as the zebra, still keeping in mind all the evidence-based data that we have. And cultural intelligence is tied together by emotional intelligence. We have to have some semblance of emotional intelligence to achieve cultural intelligence. So again, and this I'm going to go through quickly because I just told you all that, but just knowing that in addition to being motivated to wanting to know more and work with people from different backgrounds than yours, you also have to be motivated to interrupt and manage those biased influence decisions. In terms of the strategy, we talk a lot of times in my circles about playing chess and not checkers. The same thing with this. Those strategies need to be intentional. They need to take the time, the effort, and the space, make the space to interrupt, again, all of those systems and processes and policies, and doing that boldly with that courage to make those changes happen that are sustainable, so that I'm even saying by 2030, we can see that some changes have happened in terms of the social determinant goals. And I already talked about that. I love this picture about change and chance, because we've been, I think, going, just taking our chances and doing things on the fly historically. But if we are intentional about how we're going to change processes and policies and systems, then we can really impact those determinants of health and those outcomes, because real change is not an event. It requires repetition. So this will be a continuous journey. And again, I talked about some of these already, about the benefits of cultural intelligence, but the bottom line is the improvement of outcomes and the respectful curiosity, meaningful understanding, because people know when you're authentic and really impacting systems change, so that we don't just judge people thinking that we don't care about our health. A lot of times, that is in the literature, that people, in terms of biases, often assume that Black people have less positive outcomes because we don't prioritize health. But if you truly understand the social determinants of health, you understand that that's not the case. So this is another one of those action items that you will see in the PDF that will be provided to you, but I wanted to show you that this flex model directly aligns with the cultural intelligence framework. So these are two in one that helps with bias mitigation and management, because some biases you can mitigate, but some you may not. So let's be solution oriented, thinking about the problem. And we talked about blind spots. So when you think about when you're driving in a new environment, you get nervous. Same thing with this work, even though it's not new, but because we're being so forceful about making those changes happen, people are nervous, but we do need to be hyper vigilant in positive ways. So thinking about if you're driving in LA, used to driving on an interstate that's 3 lanes, and now you're driving in LA and it's 6 lanes or 8 lanes or whatever. You do want to check your blind spots before you change lanes. And oftentimes we depend on those mirrors. And the mirror doesn't always help us to see what's in there. So it's a little bit more difficult. We want to turn around and we readjust the mirrors. We want to change the body language. Same thing in this, it's changing the processes and the systems. So having those conversations about prioritizing the actionable items and the systematic processes, and what should those processes look like, acknowledging that what, exploring the cause, the why, and exploring some of those solutions. And again, knowing that this is a work in progress and there is no one size fits all. So this is how you get results. We want to change the narrative through self-education, information literacy, critical consciousness, and being an upstander, not all the time, not sometimes rather, but all the time. And that doesn't mean acting in the moment. We can always think about and reflect on things and change some of those processes. But information literacy, knowing what's true and what's not, what's real and what's fake, very important right now, and not the superficial learning sometimes, not the box checking. We want to get a deep understanding. That's the cultural intelligence piece again. So one last video is short, but this aligns with the upstander. If it shows, yeah.
You know that little voice in your head? The one that tells you to ignore a tasteless joke.
The one that tells you to keep quiet when a client makes a racist comment.
The little voice that tells you you're not smart enough because English isn't your first language.
Or that it's okay to judge someone for leaving early because they have family commitments.
The one that tells you not to say anything when others are being reduced to stereotypes.
Or that it's not a big deal when everyone's opinion isn't considered.
You may think you're the only one that hears that voice,
But that voice also speaks to other people. It says, "You're different.
You're an outsider.
You lack commitment.
Your opinion doesn't matter."
Instead of listening to that little voice, you need to find yours and make it heard. It's time for all of us to speak up. Because when we change the dialogue, we can change our world.
I'm going to add to that, speak up for health equity. So you can type it in the chat, but a time when you heard a voice in your head, how did you respond to that voice? And if you didn't respond to it, now that you know better, going back to that Maya Angelou quote, what would you do differently, or what will you do differently next time? So I love this John Lewis quote: when you see something that's not right, not fair, not just, you have a moral obligation and a mission and mandate to stand up, to speak up and speak out, and get in the way, get in trouble, good trouble, necessary trouble. And this is good trouble if we're truly going to impact, again, those objectives from the social determinants of health, because it doesn't pay us for the knowing. We already know that, but what are we doing with what we know? Just bringing that point home. So thank you. And now we're going to move into our breakout sessions. This is a long scenario. I don't know, Kara, if y'all put it in the breakout room so they can still see it.
Yeah, we can have the facilitators read through it. Everyone should have a copy of it and can share